I was going to talk about cure in CLL and where we are currently with this idea of cure in CLL. But before I do that, can I have show of hands? How many of you are patients? Okay, almost all of you. How many of you are on treatment currently? A few of you? Or been treatment, yeah, or been on treatment, yeah. So if I say to you, so the two primary questions is, obviously how can we cure CLL, but a step before that is, do we need to cure CLL? Okay. So if I say to you that you have CLL, you've had treatment, you had some residual disease, but you can live with that. So how would that make you feel? Would you be happy with that? No? No? Why not? No, but you had treatment, you got a little bit of residual CLL left, it's not affecting your quality of life. Well, why would you want to cure?
But what evidence have you got that it's not going to get aggressive at any one point?
Yeah, that's a good point. Yeah. Any other feelings?
Well, you'd like to feel confident for the future.
Yeah, absolutely. Yeah.
You don't know how long these things will last. It's the same point. I mean, nobody knows. I'm on ibrutinib.
For 4 years, yeah.
Yeah.
3 years, 4 years, yeah.
But you don't know that it will last forever.
Yeah. Yeah. So a lot of not a lot. Some of the hematological cancers have now been cured. In particular, childhood acute leukemias. Childhood acute lymphoblastic leukemia. Decades ago, we never thought we would be able to cure childhood leukemias, but now we are. If you look at the literature about CLL, it always says that CLL is a commonest type of leukemia in the Western world and is incurable. Both these sort of terms go hand in hand. But is it incurable? Let's find out. So this is, I've highlighted this paper just simply because if you look at this data, it's 2018, so this year, okay? This article is from this year, and it still says over here that CLL is an indolent and an incurable condition, okay? So we're still not there for curing it, but I can tell you where we are reaching there. There's a very important person recently said that eventually we can cure everything, all medical conditions. Do you know who that person is? Any guesses? Trump? Close, very close. It was actually her. Any Doctor Who fans here? Doctor Who fans? No? Yeah. Anyway, so the first step towards cure is something called as MRD negativity. Have you heard of this term before?
Yes.
Yeah? Some of you shaking head, no? So MRD negativity is something where we don't find any residual disease. So MRD is minimal residual disease. So once you've had treatment, we do a repeat test either on the blood or bone marrow and see if there is any residual CLL left. And if there isn't any residual CLL left, what we say is you're MRD negative. Now this does not equate to cure, okay? And the reason for that is the MRD negative status can become MRD positive at some point, and I've got some slides to show you why that is clinically significant here. Does anybody know who is MRD negative? Anybody over here who have been told you're MRD negative? Yeah? What treatment have you had, if I may ask?
Sorry?
What treatment have you had? FCR, yeah. How long ago?
Finished 2 years ago.
Yeah, okay. Yeah.
I finished in June.
FCR, yeah? Yeah.
Bone marrow.
Yes, of course. We had discussion recently. Her husband is my patient. But yeah. Anyone else? MRD negative? Okay. So the important questions are, what is MRD negativity? Why is MRD negativity important? And how do we achieve this? Okay. So as I mentioned, MRD negativity is no CLL cell detected by the current high resolution techniques. Okay. And the reason I say current high resolution techniques because the goalpost keeps on changing. So many decades ago, if you had CLL, you had some treatment, your hematologist would look at the cells in the microscope and say, oh, CLL are gone, so you are MRD negative. Perhaps that was MRD negative definition in that era. So that's, there you go, they're CLL cells, you can see them, and if they're gone, then they're gone. But in 1992, there was invention of this machine called a flow cytometer, where we put a one drop of sample, 1 milliliter of drop of blood or bone marrow, and then it can detect CLL cells in 10,000 cells. Okay, so that's the detection limit that we currently use, and a lot of clinical trials use this sort of technique. And if we can't detect one CLL cell in 10,000 cells in a drop of blood, then we can be confident that is MRD negativity. Okay. There are some other techniques which have been used, which are sort of, it's just a medical word, but it's more high resolution technologies, uses much deeper analysis, to detect one CLL cell in a million cells. Okay, so you can see over the years the technology is improving. So the MRD goalpost may keep on moving, but there are techniques which we can use to detect one CLL cell in a million cells, and that's really, really deep. Okay. It's time consuming and it's expensive. So this is what I wanted to show you. Okay. Say for example, if you had chlorambucil and you had some response, you see the number of CLL cells which can be detected. If you have fludarabine, you do a bit better. And this is what we use, conventional CR, that is complete remission. Conventional complete remission is when there is no CLL detected on the blood, hematological response when we look at the cells under the microscope, and also the full blood count is normal. That's a conventional CR. Okay. What we are over here at MRD negativity at this point, but our goal is here. And the modern therapies, which I will touch in a minute, are somewhere around this mark. Okay, so we have a fair way to go, but that's where we are currently, and that used to happen before. So if we reverse and go back a few decades ago, in 1960s and 70s, alkylating agents had only 5% CR, and we're not talking about MRD negativity here, we're just talking about CR. In the 80s, so purine analogs were discovered, especially fludarabine, which is still being used, obviously, which improved the CR rate further, and a combination of purine analogs and alkylating agents, which is F and C, okay, that further improves the CR rates. Of course, there's a big trial in 2010 called the CLL8 German trial, which recognized that fludarabine, cyclophosphamide, rituximab, FCR, is significantly better than them alone, and so CR rate has further improved. And with the new novel therapies, CR rate has been improving. I've got some slides to show you in a minute. So why is MRD negativity important? As someone mentioned, we don't know, you're not confident when the CLL will relapse. Somebody said prognosis. Obviously prognosis is also important. Quality of life, yes, quality of life is important, because if you are MRD negative, you can be confident that the CLL is not going to come back for a long time. Okay, and that also gives the individual patient, time to get on with their life. So we know that deeper responses means longer survivals. So if you are MRD negative, obviously you live longer. There is clear evidence for that. It's a marker of prognosis, and it's also a target for future treatments. Okay, I'll touch that in a minute. And the reason I put your targets for future treatment is, if someone is MRD negative, or if they've got very little CLL left, we can use other treatment options to mop up the CLL, if you may. And I'll come on that in a minute. Okay, so this is just there are lots and lots of examples, and there's just one example of a paper that was published recently, that if the minimal residual disease is an independent marker of more than 10-year survival in CLL. Now there are lots of different markers. You may have heard of IGVH mutation, you may have heard of cytogenetics, but minimal residual disease is an independent predictor. So if someone is MRD negative, okay, you could be confident that you have a good future in CLL, and you may not require any other treatment in the future. And also, stopping treatment. Okay, as you mentioned, you're on ibrutinib for 4 years. How long do you continue the ibrutinib? Who knows? You know, there are trials which are now looking at stopping ibrutinib at, after a while, to especially in patients who are MRD negative. So, some of you may have heard of a condition called chronic myeloid leukemia, which is slightly different than chronic lymphoid leukemia, but the treatment is very similar in the sense that the tablets they take is very similar to ibrutinib. Is a TKI, which is a tyrosine kinase inhibitor, and patients have been on this for a long time, and now we're looking at trials to see if we can stop taking these tablets, and again they are being monitored by MRD status as well. So we can take some lessons from there. And before we, as we know, the median age for diagnosis of CLL is about 72. So we know that this patient, this condition mainly affects patients who are slightly older. So before we talk about treatment, functional assessment is very, very important. Okay, so you don't age itself is not a contraindication for giving a type of treatment, but functionally how fit they are. I was talking to a lady recently. I saw a patient this morning who had CLL but was having SLL mainly in the lymph nodes, having bendamustine plus rituximab. He's 80 years old and he has ran 103 marathons. 103, I was completely shocked this morning. I said, no, that can't be right. He said, yes, I've run 103 marathons. So extremely fit, extremely fit. So talking about MRD negativity, you may have heard of this trial called Clarity. Have people heard of this? It received some coverage in BBC News, and this ran out of Leeds, and Pete Hillman was the CI for this trial, and this looked at patients who had relapsed CLL combining venetoclax and ibrutinib. Okay, anybody on this trial in this room? No? Anybody know anybody who was in the trial? Yeah? You know someone who has been on? Yeah. Yeah. So this, he's MRD negative, yeah. So this trial looked at a combination of ibrutinib and venetoclax for patients who are relapse or refractory CLL. There are only 50 patients, so numbers are small. All these trials I'm going to show you. I'm going to show you what the evidence is, but please bear in mind the numbers are quite small. And about a third of the patients who went into this trial were MRD negative at the time of analysis. Okay. 30%, that's very high numbers. And as a result of that, this combination has been adopted on the FLAIR trial as well. And now there's an arm on the FLAIR trial which has got venetoclax and ibrutinib. Anybody in the FLAIR trial in this room? You in the FLAIR trial? You got FCR, what, sorry, I didn't, monotherapy. Ibrutinib monotherapy, okay. Of course I know, yes? You got FCR on? No, FCR. You got FCR, yeah? Obviously FCR, yeah. So FLAIR trial is the UK trial. Obviously, is doing extremely well. They've already passed their targets for recruitment, and there are few more years to go. King's is the highest recruiter. Somebody was from King's over there. Yeah, King's is the highest recruiter in the country, and UCH is the second highest recruiter for this trial. So third of the patients are MRD negative in that trial, and for those patients who are MRD negative, after 12 months of treatment, the treatment is stopped completely. Okay, so that's something we should be aiming for in the future. That A, to receive a MRD negative status, and B, thinking about stopping treatment. FCR, obviously, we have very good data about FCR, who does this job very well, but not everybody is fit for FCR. FCR has got some side effects, lots of side effects, especially risk of myelodysplastic syndrome or secondary cancers if you've had. So, if we can get away from FCR but still get a very good result, that's what we should be aiming for. I don't want to overload you with a lot of data, but I just want to show you where we are with the trial. So this is, for example, this is a CLL14 trial, which looks at venetoclax in combination with obinutuzumab for patients who have got coexistent medical problems or have got comorbidities. And you can see, again, numbers are very small, only 11 patients in this trial, but 91%, so 9 out of 10 patients are MRD negative. You can see 10 raised to minus 4, so they don't have even one cell identified in 10,000 cells of CLL. Very impressive results. Okay. This is a trial called Murano trial. Again, this received quite a lot of press recently at the EHA conference earlier this year. And this looked at a combination of venetoclax plus rituximab along with bendamustine plus rituximab. Okay. Anybody had bendamustine over here? Yeah? How long ago? 6 months ago. Okay. So, and what you had before bendamustine, or was that your first line of treatment?
That's my first line.
This first line. Yeah. So this blue bit shows the number of patients who are MRD negative. Okay, and in this arm and in the BR arm. So you can see over here at 9 months, for example, and certainly at 18 months, very few % of patients are MRD negative. But if you combine venetoclax along with rituximab, you can see over 50% of patients, or more than 50% of patients, are MRD negative at 18 months. At 9 months, 62% of patients were MRD negative. And in this trial, they stopped the venetoclax at 2 years. Okay, so you can see the theme is people are trying. What they're trying to do is stop treatment at some point. Very large number of patients are getting MRD negative. There's another trial called CLL11 trial, which looked at obinutuzumab and chlorambucil. This combination is now a nice approved first line for patients who are not very fit, have got comorbidities, and who are not fit for FCR. So instead of BR, you could have this, and you can see over here, MRD negativity in the blood, 37%, in the bone marrow, nearly 20%, as compared to only 2% if you have the rituximab and chlorambucil arm. So you can see people are trying to achieve this. If you are in America, MD Anderson, if you live anywhere in Texas, and if you have IGVH mutated CLL, what the thinking is of Americans that we try and reduce the chemotherapy as much as we can. They certainly don't like FCR at all, because there's the risk of the MDS and risk of secondary malignancies. And what they have tried to look is, instead of 6 cycles, if they do something where they can reduce the number of cycles, yeah. So the FC they only give for 3 cycles along with ibrutinib and obinutuzumab. So yeah, they are giving like all the best drugs available, which they can give. We unfortunately can't give in the UK. And they've also selected this group of patients who we know would do very well with FCR. So IGVH mutated status patients who have this CLL, they do extremely well. We know that from lots of previous clinical trials. So what they've designed is they give 3 cycles of this, and then they drop the fludarabine and cyclophosphamide, just give ibrutinib and obinutuzumab for another 3 cycles, and then give 6 months of ibrutinib alone, and they stop after 12 months. Okay, and vast majority, 90% of the patients are MRD negative. That's huge number of patients. Okay, and again, we talk about the cost, we talk about burden in healthcare. I mean, David spoke about his sort of interaction with NHS England and NICE. If you're going to offer a therapy which is expensive to begin with, but you can stop them after a year, surely we need to look at that cost model, because it may make more cost effective. Okay, as opposed to someone's on ibrutinib for n number of years endlessly. This may be a way forward where we can identify selective patients, not everyone, identify selective patients. By the way, this is what they do in MD Anderson, even off trial. So even if you're not in clinical trial, you would get this combination. Again, this is the same trial. It's very, very small numbers, but you can see at 12 months time, there were 19 patients, and they all were MRD negative. Very high number of patients MRD negative in the bone marrow, so not even blood, but in the bone marrow. Yeah. Almost all of them MRD negative. So the conclusion is that, we have all these drugs available, okay. Single agent ibrutinib or single agent idelalisib, somebody was on idelalisib on that side? You're on idelalisib, single agent ibrutinib or single agent idelalisib perhaps may not do the trick. What we need to do is combine these drugs, and the clinical trials which I've shown you just now uses various combination of these drugs to achieve a MRD negative response, and that is the first step towards getting a cure. So what do you do next if you have little bit of MRD positivity, or if you are indeed MRD negative? How do you ensure that that you are going to be cured of your CLL? Okay. Have you heard of other treatment options in CLL? Anyone? Apart from these drugs? Stem cell transplant. Yes, we not talked about stem cell transplant. Sorry, you said something? CAR T. Yes, CAR T. So CAR T cells and allogeneic stem cell transplant. Okay, we know allogeneic transplant can induce cure in CLL. The results for CLL are not as great as acute myeloid leukemia, for example. There's lots of comorbidities associated with allogeneic transplant, but we know in principle allogeneic transplant can cure CLL. CAR T cells. Does anybody know what happens in CAR T cells? Yeah, you are quite knowledgeable of CAR T cells. Yeah. Yeah, you go through apheresis. There's a long, cumbersome process where you activate your own body's T cells and program them in such a way to attack the CLL. And patients, CAR T cells are used in various malignancies. And I'm not going to go into great detail of CAR T cell therapy, but the point of principle over here is that the T cells are programmed in such a way that they do the job of what the chemotherapy would do, i.e. go and kill the CLL cells. Okay. But again, it's extremely toxic and quite cumbersome. It takes a while. BITE is another sort of bivalent antibody. I've got a picture I'll show you in a second, which it sits on the T cell and the B cell, and it gets the T cell do the job of any chemotherapy and mop up any residual CLL is available. So, which is there to mop up. So, what I'm trying to say over here is, A, we need a very good response, and the combination of these new drugs can, we can achieve that, and B, and then we can use any of these therapies to see if we can improve the response that we have had. We are planning to set up a clinical trial at UCH using this blinatumomab. We know blinatumomab works very well in acute lymphocytic leukemia, ALL, and we want to see whether you can use the same principle in CLL. So this is just a pictorial representation of what happens in a CAR T cell therapy. You get yourself apheresis, harvest your T cells, program the T cells in such a way that it attacks, program your T cells, grow lots and lots of T cells, and then inject the T cells back into the patient, and then it will do the job where it kills the tumor cells. When this happens, this is where the risky bit is. There's a lot of cytokine release, the chemicals are released, and patients often need to go to ITU. So it's not for someone who's got comorbidities and other medical problems, get into trouble with that. And this is what I just mentioned, the blinatumomab. This is this drug over here which sits on this T cells and the tumor cells, and then it engages this T cells to kill the tumor. So again, if you got very little CLL left, after your initial therapies, you can use these drugs, to get rid of it completely. Okay, but the key points over here are we need to use these drugs earlier in the treatment. Okay, so if you want to use idelalisib or you want to use ibrutinib, as David has mentioned, you can't use this first line if you are not on a clinical trial. Okay, you can get bendamustine if you are not fit for FCR, but you can't get ibrutinib. So, I think we need to reach to a stage where we can use these drugs early on. We also need to reach a stage where we can use this sequentially. So, perhaps use ibrutinib in combination with something else first, and then venetoclax, or whatever it is. The sequence needs to be there. Obinutuzumab, there's a lot of data about obinutuzumab. It's better than rituximab as a combination with other drugs, which obviously we need to think about, and we think about cost. As I said before, someone needs to do a proper cost analysis as to is these drugs upfront, are they really that expensive? Probably not. If you use them upfront in a way that you can stop after a year or two, then it may be cost effective to use these drugs upfront. So again, just to refresh memories, what we have is a CR over here, complete remission. This is what we call as MRD negativity, this red line, but cure is somewhere over here. Okay, so we need to get to a stage where we can probably achieve this. This is the first step to achieve, and then going on whether we can achieve this. People say it's not possible, it's not needed, but actually we have shown in other hematological malignancies that this is possible, and we can get to this. Okay, so please ask questions.
Thank you very much, Parag.
Yeah.
So we're going to take some questions from the floor as well, but if you can fill in, if there's any that you want to put in as your table group, fill it in block, and the trustees will collect them in. But I'd like to give a round of applause to that to start with.
Yeah, thank you.
While you're filling in the forms, can we take a couple of questions?
Yeah, go on.
And then we'll take new.
Yeah.
Last comment on your slide
Yeah,
mentioned cost.
cost, yes.
Clearly there's a political element
Yes,
that's
absolutely.
associated to
Yeah.
that. As an organisation, can we as the CLL lobby in any way that will help you as clinicians and aid your frustration to enable you to prescribe the best treatment for us rather than be restricted by political views?
So this is a very
Sorry, I realise it's controversial.
it's
but-
controversial. It's complex. We need to go by evidence. Okay, so if you think about where we are at the moment with FCR, it's taken us a long time to get where we are. There are lots of clinical trials which are happening all over the place, especially the FLIRE trial, which I think when the results come out, which will find that FCR is probably as other drugs are as good as FCR. Other drugs may be the gold standard. So I think it takes a while to come through, but we would get there. Yeah, and of course, if we need to lobby, obviously patient association is a very strong force for that. Yeah, absolutely.
Thank you.
Is this on, Parag? Parag, similar question really.
Yeah,
Not just cost, time.
yeah,
MRD negativity is
Yeah.
a surrogate marker.
yeah. That's right.
Trying to get the payers to actually understand the validity of that. You showed evidence there of 10-year evidence survival for MRD negativity.
Yeah,
But also the trial designs so that
Yeah.
meaningful endpoints are actually
yeah,
established so that median endpoints are achieved in a trial so that we can
Yeah.
get these accesses through. So the question really is, what do you personally think is a timeline to be able to get these combinations early into the patient pathway to actually
Yeah.
to get a cure? Because we do have a research problem, and I'm just about to bring it up, because
Yeah.
rather than investing just in the charities,
yeah,
I think we have a bit of a crisis at the moment in CLL funding of CLL-specific trials in the UK
Yeah.
to carry on with the early access, the accelerated access program and TAP and FLAIR for it to eventually
Yeah.
achieve what you've said.
yeah.
So my question really is, what do you realistically think is the timeline that we will be able to get these into routine commissioning, and can we? And what do you? A second question is, when do you think NICE, as an appraisal body, will accept MRD negativity as a meaningful outcome measure?
So that will take a long time to answer your second question first. MRD negativity, although there is a lot of trial data, as you can see, the numbers are quite small. Okay, so for NICE to change the recommendation, they will need a bit more robust data, a bit more strong data over a period of time before they can recommend MRD negativity as a marker of changing treatment or stopping treatment. Okay. Going back to your question is, I think the sequence will change very soon. So we may not need to wait for the full results of the FLAIR clinical trial, but I think venetoclax will be available a bit sooner in the treatment schedule very soon. We got to work with the pharma companies as well on this. So, for example, there was early access scheme for ibrutinib, there was early access scheme for CLLSA, and there was early access scheme even for venetoclax, which a lot of patients have accessed. And I don't know if you have seen George Follows from Cambridge. He's done analysis of UK-wide patients who got on the early access scheme of ibrutinib. And
5 years data now.
yeah, he's got a 5 years data and see how well they've done or not. But the point being, a lot of patients benefited from that early access scheme of ibrutinib.
Thanks for your answer.
Yeah.
Can I give you those two?
Yeah.
Hang on.
Can I just comment on
Yes,
that? And I'm
Dima.
going to be a bit controversial here,
Yeah.
Parag, and put
Yeah.
you on the spot.
Yeah.
But the MRD data is
Yeah.
with chemotherapy, the ones that we've got long term. What we don't know
Yeah.
is with ibrutinib, you might get similar MRD data, but we don't know that it's going to translate to duration of response. And I'm not saying that this is right, but the ibrutinib could be changing the CLL cells. So you could get rid of most of them, so that you're down to your 1 in 10,000,
Yeah.
100,000. But if they're more aggressive and they're going to come back and become more aggressive, more resistant to treatment in the future, the data isn't there yet to say that
No.
it is best to give it up front.
No, that's that's right.
And it
That's,
could be that it is the right thing to do, but I
That's
don't
right.
think the data is there yet to say that.
personally, I feel that ibrutinib on its own may not do the trick. You need combination therapy, and that's why I said the combination is the key. We know from the interim analysis of the FLAIR trial, so FLAIR had 4 arms, and 1 arm was taken away, rituximab and ibrutinib, because we knew it was adding rituximab was not doing any benefit because ibrutinib was working so well. But we also know that patients who are on ibrutinib alone may not get the MRD negativity status on its own. We know that. So, as compared to patients with FCR, with combination, they're doing very well. So, I think it's just a matter of getting more data. And as I said, the numbers are quite small in the clinical trials. We just need more evidence. But it's looking positive, it's there. We're on the right track. Yes, sorry. So, there's a question here. FCR is described as gold standard treatment previously by Dima. What is your opinion in the best option currently for treatment for CLL? So as I said, the evidence is for FCR. It is the gold standard. So if you were not on a trial, you should get FCR, because we know from the CLL8 data that is the gold standard, and that is very good. Yes, a small number of patients will have complications. Small number of patients will have a risk of MDS. But if you're in UK, I would recommend that you have FCR. If you're in America, obviously things are different, because the medical healthcare works completely differently over there. If you're going to go purely on evidence, you should go with FCR.
Does that comparison take into account all the side effects, the SAEs?
Sorry, I didn't get a question regarding.
So you said FCR is
Yeah.
the gold standard.
Yeah.
So are we taking into account all the SAEs?
So I'm taking into account the responses and MRD negativity. There's
Looking at SAEs as such.
no. Okay. The next question: is there any other trial than FLAIR? Captivate. There's a Captivate. So there are no currently sort of trials on the radar. In fact, I'm going to a NCRI trial meeting tomorrow where we'll discuss all the UK trials. There was, so for example, for patients who are not fit for FCR, unfortunately there are no trials at all. There used to be a trial called Rialto trial, which now is stopped for recruitment. So patients who are not fit for FCR, there isn't any clinical trial available. There may be some clinical trials coming up for relapsed patients, especially use of other drugs like ibrutinib, like ibrutinib. Not sure if people have heard of this drug, but it's a second generation ibrutinib, and there are some clinical trials in the pipeline. But unfortunately, as you mentioned, the research is very slow in CLL. So BR, I mean, there isn't a gold standard because you can't compare BR with FCR. Well, there has been a comparison in the CLL10 trial where they compared FCR with BR for patients who are more than 65 years of age, and that showed superiority of FCR over BR. Okay, but there were lots of significant toxicities in the FCR arm, and hence BR has been pitched. The thing is that the landscape of CLL is changing very fast. So, for example, now we have approval from NICE and NHS England to use ibrutinib as second line. Even if they've had 4 or 5 years of CLL in the past. So, so things will change. Things will change. There's a question here. Okay, mopping up the last few cells after the medication was mentioned. Why can't this be done when first diagnosis and when when there are very few cells? So, as we know, majority of the patients with CLL will not require any treatment in their lifetime. Okay, so to subject them to toxic treatment, when we think they don't need it, it's not a good idea. Sometimes we can do more harm than good by treating them upfront when they don't require any treatment. So we try and delay, and somebody mentioned watch and wait is like watch and worry. It is, but if we can delay as much as possible, that would be better than treating upfront and getting all the toxicities. So, it's a slow-growing leukemia. A lot of patients may not require treatment at all, so it's best to avoid if we can.
Is there a final question? Okay, from the front, that would be the last question.
I mean, a number of people on ibrutinib react badly and therefore have a reduced dosage.
Yeah.
Is there any evidence to say how those people are reacting or how their CLL is reacting?
Yes.
Once they're on the reduced dose?
Yes, there is evidence. So there have been, again, some American clinical trials where they have randomized patients to have the full dose ibrutinib and give a reduced dose of ibrutinib to see what happens. And in fact, I don't have results over here, but there is some data emerging that one tablet is also enough. Once you are in the maintenance phase, you can even have one tablet, which is good enough. Yeah, but certainly two would be great. You don't need 3 tablets. There is some data emerging on that. That's a very good question. I mean, pharma companies are quite notorious. So what I heard they're doing in America is they're coming up with 1 tablet of 420 milligrams, as opposed to now you take one tablet of 140 and you take 3 of them. So to the same price, yeah. So that.
Thank you very much.
Yeah. Thank you.